Welcome back, everyone. I hope everyone enjoyed your lunch and now are ready for some engaging discussion on the topic of early health technology assessment or early HTA. So this afternoon, we will dive into a critical question. Are we too early to define priorities in HTA? But before we start the discussion, let's extend a warm welcome to our esteemed chair of this session, Professor Maarten.
Thank you very much. It's fantastic to be here. Thank you, Dr. T, for the introduction. I have no conflicts of interest to declare, but I'm excited about this topic. After a fabulous lunch, we're here to talk about early HTA. So what is this concept? What is early HTA? Maybe I'll ask you first. Dr. T, you are here on stage. Can you tell us, what do you understand by early HTA? Give us a sentence.
A pop quiz.
Go, let's
So early HTA is when you do evaluation early.
Okay, that's
now,
going to the right place.
So this is when assessment of a medical technology or medical product happens early during the R&D process or early in the product development cycle. And this is when you don't have much evidence about the technology just yet.
Great. There's a lot of stuff there, but we have 4 very esteemed speakers who are experts in this area who are going to tell us more. But before we get to them, let me ask all of you that same difficult question. So we've got a mentee quiz here. If you can bring out your phones and scan this QR code. I'm going to ask you the same question. What do you understand by early HTA? So give you 5 seconds to scan the code, and then maybe in about 10 seconds, we can change the word cloud and see what people understand about this concept, early HTA, which we all interrupted our delicious lunch because we knew we had such fabulous people to tell us about it. Right. Great. Maybe can we switch to the word cloud and then, am I the one to do it?
Yes.
Okay.
All right, we got it.
Okay. Do we have the... great. Okay, it's time to type your responses. Give us a sentence, give us a word, give us whatever you like. Dream, impossible. Wow, okay. You are going to tell us how to do the impossible. Uncertainty, innovation, crystal ball, early, emerging. Wow, these are...
Innovation.
These are very adventurous statements, actually. Yeah. Pragmatic. Okay, now we're coming back down to earth. HTA before program. Great. Horizon scanning, before market authorization, political pressure. Wow, okay, no data. Great. Okay.
Somebody say hard. Yes, it is hard.
Great, this is fantastic. We've got 42 challenging words, and now we're going to have a bunch of incredible speakers to put flesh into them and tell us what all this is about. So to start with, I'm going to welcome our first speaker, who is Professor Maarten Ijzerman, who is the Dean and Professor at the Erasmus School of Health Policy and Management in Rotterdam, but also a visiting professor at the University of Melbourne Centre for Cancer Research. So he'll be giving us a global view of the key concepts around early HTA. So over to you.
Fantastic. Thank you very much, Mark, and also thanks for stepping in as a chair for this session. I particularly would like to thank the organizers, HITAP in particular, to invite me for this brilliant symposium and talk about early HTA. I have no conflicts to declare, other than that I'm not a health economist. I was trained as a biomedical scientist with a PhD in biomedical engineering. And to say a few words about that, because that was also the reason why I was intrigued by early HTA. As a biomedical engineer, I was working in the field of neuroprosthetic devices, brain-computer interfaces, and all of a sudden we thought, what's the value of this kind of technology for patients? And that's, of course, a very important question, particularly in the development stage. And if you talk to engineers and SMEs working on the technologies, they always talk about what we call the valley of death. Here on the left, beautiful picture, Death Valley, as you know. But the valley of death here is in the middle, where you see at the product launch here. Yeah, that works. that's where the actual uncertainty is, whether the product will be feasible and implementable from a systems point of view. So that's the valley of death, and we all have to pass the valley of death. And that's a concern to many companies and many engineers in the field. So that was my interest, and with that interest and background in engineering, I wanted to share a few things of my experiences in 3 messages, and we've been given 10 minutes, so try to make it happen in 10 minutes. First, I want to talk about confusion and concepts, because there's a lot of confusion about the word early HTA. Is it early? Is it very early? What is HTA here? The second one is the challenge of early HTA and complex technologies, because it's very easy to think of early HTA when you know what product it is and what the specific population you're targeting at. But it gets more messy when there's a multi-purpose technology or whether there's different patient populations benefiting from the same technology. So that's the second challenge. And the third one is, what value metrics should we take into consideration? Is it just the ICER, incremental cost effectiveness ratio, or should we take a more broader view, including things like carbon footprint in our development pathways? So let's go back to my experience as a biomedical engineer. And when I was in my engineering, I got my PhD in 1997, I started to do a course in York with Mark Sculver, and I started talking to Mark Sculver, and he has really published a very nice paper about what he called iterative economic evaluation. And at that time, it was really to build the economic evidence along the clinical evidence pathway. So phase 1 clinical research, phase 2 clinical research, and you can, in the different stages of clinical research, you can also build your economic evidence. So that paper was published in 1997, and that was for me the very first start of thinking about, can we use this in one way or another for early HTA? The second experience I had with talking to Jan Pietsch in Stanford, and the work that we've done in our group in 2011, so 13, 14 years ago, where we thought about what is early HTA. And at that time, we defined early HTA to be all the methods, so very broad and comprehensive, that can be used to inform industry and stakeholders about potential value of new technologies in development. So technologies in development, that's critical to recall. Then also translational health economics was introduced by Wolf Rogowski some time ago. And very recently, I also came across work with an HTA on development-focused HTA. And that's quite interesting because that's a new term, in my view, for the same concepts. It's about technologies in development. And this is about an HTA focus. And I think, again, I would take a more broader perspective on what is it that we can inform. And then finally, life cycle HTA has also come to play. And I think the life cycle, that's a little bit of a different ballgame because it's about technologies that are already on the market, where we do re-evaluations, for instance. So those different concepts are there, and we all have different meanings about what is early, what is very early HTA. I would like to go back to Jan Pietsch's paper in International Journal of Technology Assessment in 2008, defining classical and early HTA with 2 very important things to remind here. The first one is that early HTA provides decision support for manufacturers and investors about the design and the management. So the technology is in development, it's not ready yet. So that's the first thing to remember. The second one, and that's very important, the assessment has a potential impact on the future performance of that technology. So it's still changing. And that means that the product is not in place yet. It's still developing. And those things, for me, define early HTA. Well, then you can look, of course, into economic modeling, and you can do some very simple examples like a decision tree. That's a very simple takeaway from an early model that we can develop once you know the specific product that you're targeting and the population that you're looking into. So we've got a specific disease X, we've got a current treatment, we have a potential new treatment. All we have to do, we can populate this with real-world data and other registries. The only thing we have to do is to estimate the anticipated performance of our new product. So that's all we do. So we need expert elicitation to estimate that 10% success rate or 15%. That's a very simple concept of early modeling for a product which is nearly ready for product launch. There's other methods like the headroom. It's also a very straightforward method in particular in those jurisdictions using ICERs and a willingness to pay, you can estimate for a new product, and let's say again, so we've got a current treatment, for a potential new treatment, we can estimate the future quality gain for that new treatment. And that's an expected quality gain. And given your willingness to pay threshold, you can obviously also estimate what the acceptable incremental cost could be. So you assume we have $80,000 or euros per quality, we can estimate the acceptable cost, the marginal acceptable cost. And then we have to estimate if we would develop our new product to a successful market launch, what can be the cost to be under the threshold, the willingness to pay threshold. And in this case, we've assumed that the expected cost is here of the new device, including the implementation, and that means that the gap that's here, that's a value for the buyer, for the government. They save money by buying the technology. So this is what we call headroom or cost effectiveness gap analysis. It's been used all over the place, many different studies. We've done a few in the past. And most interestingly, there's been a review recently from Boudewijns et al. In 2023 in Applied Health Economics and Policy. And they reviewed all the applications using headroom analysis. And they conclude two things. First of all, there's a considerable variation in how it is calculated. And the second, the proper use of expert elicitation methods is lacking. What the first thing means, and I can confirm from my own experience, I've seen different ways to estimate the expected quality gains. I mean, you can estimate the minimum gain you expect or the maximum gain. It has a huge implication for your headroom, of course. Or you can estimate an average gain. Or you can just do a sensitivity analysis over a range of performance gains. That's a lot of difference in heterogeneity between the different papers that used headroom. Same for the incremental cost estimates. So there's variation there. We don't know. There's no guidelines really on how to do it. The second thing, and that's for all those methods, and I like the impossible in the word cloud, the impossible and too premature. All those methods have in common that we need some form of expert elicitation. Well, there's different methods on expert elicitation. And also there will be guidance anytime soon from ISPOR about expert elicitation methods. But even there's no specific guidelines on what to use to estimate the gap. These examples are, I would say, easy. I mean, we've got a single technology, we've got a very specific patient population, and we can estimate the potential value for that specific population compared to what's already on the market. It gets very complicated with complex technologies like this. Organ printing, for instance, a platform technology can be used for multiple purposes. Whole genome sequencing, we've done a lot of that. And we can look into different mutations with all the kinds of impact and consequences for targeting specific treatments for cancer patients. Or designing drugs based on new genetic engineering, gene editing for single patients in the hospital pharmacy. So that's a platform technology that we can use for a range of rare diseases. How would you go away with those very complex technologies in terms of headroom? So for me, from a scientific point of view, that's quite interesting and challenging, but also explains why I don't think that just an ICER and why just an early economic model is sufficient to look into the value of those technologies. So finally, and I'm just running a little bit over time, I only had 10 slides, but still talking too much. What value metrics to target? I said, well, most studies I've seen do some sort of early economic modeling to demonstrate a favorable ICER. Well, to show with the very first slide, that's mainly relevant in the very early stages here. At the moment of product launch, that's where you could do an ICER because that's an informative metric to inform your reimbursement strategy. If you're way early, if you're really in a portfolio of products to be developed, your ICER is going to be meaningless. So you have different metrics that you need to decide whether it makes sense to continue to the next stage of your development. So I think the ICER is a very useful metric, but we should expand and we can use a broader range of methods to inform decisions even in earlier stages of your product development. And just to name a few, MCDA has been named, we've got real options analysis, we've got a range of methods that we can also look into. Final slides. we have never considered, and that's changed, the carbon footprint in our development pathways. We only looked in clinical evidence and the cost. This is a picture of the carbon footprint of the Erasmus Medical Center, which is the largest hospital in the Netherlands, academic hospital. This equals, the 125 kiloton equals about 45,000 people traveling a return trip by air to Amsterdam and back to Bangkok. So just to give you a number. Of the carbon footprint, 40%, you see on the left, is due to drug use, medicine use. And that includes the entire value chain, from the production, distribution, and the use of drugs in the hospital. Another 10% is medical products, lab materials, prosthetic devices. If you add it up, it's only 70% of what we produce as carbon footprint emission. So that's something maybe we should consider including in our assessments, not just early, but also in the late stage HTA assessments. To conclude, I think I've shared, and that was my purpose, that there's an inconsistent use of terminology, early, very early. What do we mean with it? That there's variation in methods used, and that the early assessment benefits from a broad range of methods, not just an incremental cost-effectiveness ratio or an early economic model. And for the appraisal of technologies, and that's more of a mission, we should include and take a more broader perspective and look into societal challenges, including our carbon footprint. Thank you very much.
Thank you very much. That was a real tour of the concept of early HTA. You answered a lot of our questions, but also posed a lot of new ones. So let's now see how this could be put into practice. I'm going to invite Dr. Wang Yi, who's assistant professor at the Swee Hock School of Public Health, National University of Singapore, as well as the co-director of the Medical Innovation Development and Assessment Support, MIDAS, that supports medical innovation in Thailand. So over to you, Dr. Wang.
Yeah. Hello. Yeah. Thanks, Mark, for the introduction. Oh yes, I have no conflict of interest to declare. Sorry. Yeah. Okay. Thanks, Mark, for the introduction, and good afternoon, everyone. For this talk, I will focus on the intersection between early HTA and the health innovation ecosystem. So to start, I want to pose these two questions. So first, is early HTA the same as conducting traditional HTA early? For example, we use the similar techniques from traditional HTA and apply them on a technology at its early development stage. And the second, when using early HTA to inform health innovation development and adoption, how to balance the tension between health and innovation? So with these two questions in mind, so here is the scope of this talk. So firstly, I will introduce the scope of early HTA, and then I will talk about using early HTA to inform decision-making within health innovation ecosystem. And lastly, I will talk about some examples. So in the real-world setting, usually the founders and the medical innovators, they will develop medical innovation first, and after the technology being developed, and with enough evidence being accumulated, HTA researchers will come in and do the evaluation, and the results can be used to inform decision-making, for example, coverage policies. But one potential issue of doing this is if the technology was found to be unsuitable for the health system, so this potentially means during the innovation process, we may waste some resource on the technology that is not value for money for the health system. And in order to minimize the loss and the risks of the R&D process, the researchers propose to apply the techniques from traditional HTA to the technology at its early stage. So based on the current literature, here are some of the main objectives of doing early HTA: to understand the nature and the magnitude of the problem, estimate the potential value of the medical innovation, and improve the medical innovation or find the settings or conditions to maximize the value of the medical innovation, and also to identify the needs of additional research and optimize the research design. And by going through these, we can potentially maximize the chance of the technology being reimbursed after we go through the traditional HTA process. So from here, we can see there is a strong link between early HTA and the traditional HTA, but I also want to highlight early HTA can do much more than just informing and facilitating traditional HTA. So when we do early HTA, we focus on health innovation. So there are actually two pieces, health and innovation. And for public health researchers, when we try to tackle the problem, we tend to start from the perspective of public health without enough focus on the innovation. So there is a large body of literature on the innovation itself, which usually receive insufficient attention from early HTA researchers. So when we work on early HTA, when we work on health innovation, so we should not just think about the health value, we should also think about how can we push the innovation process and improve the efficiency of the innovation process. So to go one step forward, we should also think about the health innovation ecosystem. So when we apply early HTA, we should use early HTA to inform the decision-making within the health innovation ecosystem. And in this way, we can also improve the efficiency of the entire system. So we won't dive deep into health innovation ecosystem in this talk, but here are three common elements scholars usually use to define or describe a health innovation ecosystem, including actors, and the nature of strategic moves, such as collaboration or competition, and also co-specialization. And for early HTA works, so when we do this one, it's quite important to do stakeholder consultation. So meaning we have to bring different stakeholders within the system together to discuss about the problem. So in this case, we have to identify all the relevant stakeholders within health innovation ecosystem, not just within health system. And in terms of strategic move, so for certain system, usually, sometimes the competition is more powerful in improving the system efficiency compared to collaboration. But generally speaking, within health innovation ecosystem, collaboration is more important in improving the efficiency of the system. So this also means, as early HTA researcher, we should also try to promote the vertical integration and try to link the collaboration across different stakeholders. And in terms of co-specialization, so within health innovation ecosystem, different actors will develop its own expertise, but at the same time, there is a strong codependency. So as early HTA researchers, we also want to find the synergies of different expertise and also think about, so for us, so what is the expertise we should develop in order to bridge the gap within health innovation ecosystem? So next, I would like to share some of our ongoing works. So as Mark mentioned at the very beginning, so we also initiate this new research unit, Medical Innovation Development and Assessment Support, in short MIDAS. So this is jointly supported by HITAP and NUS. So in this unit, we do early HTA work, and at this stage, we focus on Thailand only. So our collaborators include public organizations, venture capitals, university-based innovators, and also startup companies. So for our ongoing works, so firstly, we do collaborate with innovators working on the specific medical innovations. And these works are quite important for us to understand the innovation process on the ground. So these works serve as foundations for us to understand the health innovation ecosystem. And as we do more and more of these case studies, we also realize, so by summarizing the challenges and lessons we learned from all these products, we can also use these to inform the future R&D policies. So taking this idea, currently we are looking at the Thai innovation list. So this is a screenshot from the website of the Thai innovation list. So on the top, so you can see the blue one, the one with the largest number. So that's the health innovation. So currently, our team is reviewing all the innovations that are included, the health innovations that are included in the Thai innovation list. So we want to understand the overall characteristics of all the innovation that has been included in the Thai innovation list. And also, we want to understand the reasons for the success and the failure of these health innovations. So for example, whether they are included in the national coverage package and whether they are available on the market. And then we will summarize all these lessons, try to inform the future R&D policies, for example, about innovation prioritization and innovation support. So to move forward, so based on our previous work, so here are some of the lessons we've learned. So firstly, we should use early HTA to support the health innovation ecosystem. And through the work, dynamic thinking is very important. So when we work on individual technologies, we have to think about how the technology will unfold in the future, because the future will affect our decision now. And at the same time, we should also summarize the lessons we've learned from the past innovation and use these to inform the future innovation policies. And in order to draw all these lessons, so we need more case studies, and we also have to continuously develop the framework for early HTA. So now let's go back to the two questions I posed at the very beginning. So first, is early HTA the same as conducting traditional HTA early? So we can apply some of the methods from traditional HTA in early HTA, but we should be very clear that the decision space for early HTA is very different. And also, we need new methods to support early HTA research. And the second, in terms of the balancing between health and innovation, so typically for innovation, at the very beginning, the development of innovation is pushed by the technology development. But at the later stage, for the adoption of the innovation, it depends on the factors. It depends more on the factors from the demand side. So this transition from what we call as technology push to demand drive is non-trivial. So in this case, early HTA can play the role to bridge the gaps here. So you can think in this way, at the very beginning, we can focus more on the innovation itself, but as the technology being developed, we focus more on health issues. But more importantly, we should also use early HTA to complete the wheel and make the rolling. So we should not just use early HTA to inform a particular technology. We should also use early HTA to understand the current gaps in the health and healthcare system, and also try to summarize the lessons we learned from the previous innovations, and use these to inform the desired technologies for the health innovation system and for the health system. So lastly, go back to the question for this session. So if we take a dynamic view, so it will be never too early to inform priorities. Thank you.
Thank you very much for that. That was a great talk as well. You've put more flesh on this concept and given us a really good example as well. So just a reminder, if you have any questions for the speakers, we won't take questions now, but you can actually send them to your CVent app or ask them later when we get to the panel discussion, or we'll put up a QR code later to ask questions as well. Next, I'm going to invite Dr. Maneerat Ekkapongpisit, who is the Translational Partnership Manager at the Mahidol Oxford Tropical Medicine Research Unit. She's going to be speaking to us about early HTA from the lens of translational manager, right?
Okay, thank you, Maarten, for the great introduction. So good afternoon, all the participants. I'm very honored to be invited here to speak in this session.
Interest as well.
Yeah, so I'm going to talk about my role in Mahidol Oxford's Tropical Medicine Unit as a translational research manager. In fact, this program is, my role is as a program manager. So this is some introduction about myself. As I already introduced myself as a translational research manager. I actually into this space about 10 years ago when I joined Mahidol as a technology transfer consultant for IP licensing and commercialization. At that time, Mahidol just found the unit called Mahidol Institute of Technology Transfer and Innovation. I really enjoy the role there. And in fact, I'm very happy to see Professor Dr. Ijzerman Panit here, who is at the Mahidol Council, who found this the Mahidol Institution of Technology and Transfer and Innovation Unit at that time. So that's why I'm in this space today. I'm so happy to see you here as well. So this is my skill. I've been experienced in technology transfer consultant, doing IP due diligence, project management, do some feasibility study, business consultant, do a lot of consultant work to the scientists and researchers to help them develop the technology into the real world practice. And with this role in Moru, I given the pot of funding from the Wellcome Trust for me to manage, to help the researcher to engage in technology transfer space in the middle of the pipeline. So let's see what the pipeline is about. So I set up this the vision for this motive units, Mahidol Oxford Translational Innovation Partnership, to do three things. The first thing is translational research platform, which include the plumbing fund to give to the researcher when they want to do some research. After they got the research output from discovery research, and they want to develop some prototype and develop something to be used in the real world practice. And also conduct some of the qualitative study with the user side the demand side to see what they need in order to map between the researcher and also the patients or the user for the technology that they develop. And the second part that I do is to build the incubator. This part, I set up the TSA fund, or Technical Support Acceleration Fund, to help the researcher to close the gap. Because usually when they develop something, they always miss out the budget, the small budget. In fact, it's not much. It's about 200,000 baht something, 300,000 baht something, to conduct some IP due diligence, IP search, market feasibility study. So, or sometimes just a small prototype, the first prototype that they need to develop. So we provided funding to the researcher to help to close this gap, and also do some consultant with the extend my network expert to help them like do some IP preliminary tests, whether it needs to do the patent registration or not. This is something this incubator part do. And the third part, because this unit, it also gives the funding to the project. So I have to make a good decision. So I need a good tool to help me to guide the committee that I invite them, the expert. Because they have very limited time, so I try to maximize their time by to build this called impact measurements frameworks to help the committee who help me decide which project to fund, to make a decision which project make a good impact and which project will be possible to be funded at this stage. So this is another part that I trying to do. And also I will have another talk this late afternoon about this framework that we have developed. So, yes, Professor Maarten already showed you the valley of death. And this is the roadmap of the translational research pipeline. There are so many states that they have to go to until they reach the final goal and make the research impact or make the impact in health. So you can see it's not, I think I'm missing out. Yeah. It's not only just one valley of death. In fact, in research commercialization, in technology transfer, especially in medical research, there are so many valleys of death, not only these two that you see here on the slide. So it can be many because we have to pass through like IP protection strategy, regulatory strategy, business development, investor. There are so many states. And how early HTA gonna help me? So let me go back. So I asked myself when I give this role to be in this panel. So I would say, are we gonna use a telescope or a binocular to aim to go to the moon? So which tool that we should use? What is the best tool and when? So there are many things that we have to consider as a program manager to give out the funding. So the funding cycle is also something that we have to take the consideration. There are also like the annual budget year that we have to consider whether the project will be finished on time or not, or within that budget year, or it can be delayed, or it can be extended. The project life cycle itself, whether it's at the sweet spot that this project will thrive, because the ecosystem in that particular country, in that particular disease or environment, it also will tell whether that product or intervention that the researcher developed will success or not. The innovation characteristic itself, because we are talking about innovation, it's always the unknown. We're not sure whether this product, this technology will really serve, will really give the solution to the problem that we are going to answer that we ask. And then another thing is the cost. Because if we conduct early HTA, it also involves many other researchers involve costs in conducting early HTA. How much time and budget we have in order to spend take all of this to consider when we want to decide which project we want to fund. So, what I'm doing, I just share the experience. I'm not the expert here. I'm not the modeler. I'm not the health economist. So I didn't do all the cost-effective study because it takes too long time as well when I gotta ask my committee to decide which project to fund. So what we do in order to prioritize the area. So when I start, these are the three measures that I check. So the market feasibility, technology feasibility, and financial feasibility. And the thing that I take the most consideration is the potential impact. Because at Maneerat here, we actually work on a lot of like neglect topical disease. Our focus is more on the global health problem. Some of the issues that we deal with, it not even make any sense for a tech startup or a big pharma company. So there are no interest from them. So one thing that we really focus on is the potential impact, whether it will reduce the mortality, it will be inform the policymaker to help to subsidize that technology into the reimbursements program or not, or cost effectiveness. It will reduce the cost as a whole overall for the health system. And this is the impact evaluation, impact measurements platform that we just done recently. We just finished it past last year and we start to test it. So what we collect the data from here, we do the project description to understand the project itself and the potential research impact, which include health benefits, cost reduction, informed decision making, capacity building, or broadcasting social or economic impact. And then we also take the consideration on the business feasibility check to make sure that this product, this technology have novelty, they have the intellectual properties and freedom to operate to really make this technology that really work and really can put into practice. And the last part is project management, because we also found out that quite a lot of project is dropped off because researcher is also drop off, that they have not enough commitment to really build the product or intervention throughout the product life cycle till the end. So that is something that we have to take a note that, okay, this project, this researcher, they have enough time, they don't have too many projects on hand, so they can conduct this until the end, and they are with us till the project go to the next stage. That is something we take the consideration, and we do the scoring to guide the decision for the funding committee. This is something that we use as a motive here right now to help to make our research funding. And there are also there are other methods that people use to understand the project prioritization. So they consider impact, urgency, cost, and resource. This is something that we can use as well. And the last part that I talk about is that I will talk about is the challenge and issue of early HTA in the real world practice for research funding. So it's already discussed. So it's time. Do we have enough time to conduct the whole set of early HTA study? Or we need something quicker, easier for a funding manager like me to make a decision before next, if we get scoped down the project, then we can do the early HTA. The cost, because that you include in the cost of the project as well. Data, just now when we start, no data. So sometimes when we conduct the early HTA, I did some project with Willie right now, and we do struggle with the problem with that there's no data out there for us to do that. And the stakeholder that involved, and the last part is the medical inventor, innovator team, the researcher team. They also need to engage a lot when we conduct the early HTA. Are they interested? Will they help us to conduct early HTA or not? So, in conclusion, I think both telescope or binoculars work. It depends on when and what we ask, which question. So we can use at the right time. If you put it at the right time, the right pace. That's all. Thank you.
Thank you very much. Thank you very much. That was fantastic. Really hearing from the coalface, someone who is really needing this information to make day-to-day decisions. So that's, please keep the questions coming as well. I hear there are plenty of questions, and Dr. Dimple, if you can help us transfer them to the screen at the end, that would be fantastic. Our last but not least, we have very exciting Dr. Raymond Hutubessy, who leads the Value of Vaccines and Modeling team at WHO's Immunization, Vaccines and Biologics Department. And Dr. Hutubessy will be speaking to us about early HTA and vaccine development.
Well, thank you, Mark, for introducing me. I also would like to thank the organizers for inviting me to speak in this really important conference. And I have no conflict of interest to declare. So what I would like to share with you over the next 10 minutes is what we're doing in particular. So it's a kind of a changing gears, more from a global perspective. In WHO, and in particular in the immunization department where I work, how we use HTA concepts and frameworks that has been introduced by the previous speaker in the product development of vaccines and related technologies. So very much from a kind of a top-down global perspective, but also trying to elicit the country perspective into this development pipeline of vaccine products. So let me start with looking at immunization in the past and what can bring us in the future. So actually this month, but then 50 years ago, the expanded program on immunization was established during the World Health Assembly, which also will take part later this month in Geneva. And since then, 1974, in our department, we have modeled. We try to estimate, what the impact has been on the expanded program on immunization over the last 50 years, using mathematical models. And that publication just recently came out in Lancet, where we estimated around 154 million of deaths averted that account for 60% of decline in global infant mortality. And these were with those famous infant vaccines like measles, polio, diphtheria, tetanus, etc. Since then, the world has changed. As we all know, the population has doubled, infant mortality has come down, but also life expectancy has changed dramatically with more than 10 years globally. But also more vaccines has been coming on the market, and also more in the pipeline. And so in the Immunization Agenda 2030, we also have, for this decade, have come up with aspirational coverage targets. So what is the potential impact of vaccination over the next 10 years, counting from 2020? And again, with modeling, we have in our department tried to estimate what the potential impact could be for immunization activities. And it's, again, an additional 50 million deaths to be averted. So, focus on the Immunization Agenda 2030. And when you read the mission of the IA 2030, it's really from a universal health perspective. So, everyone, everywhere, at every age, should have the full benefits of vaccines for good health and well-being. And this mission statement I think, is really relevant for the way we assess the contribution of vaccines to global health. In particular, on how we evaluate vaccines in WHO, in particular, not only looking at the level of the deaths averted or cases prevented, but also at the distributional aspects. This is a really important issue what we also need to do in our evaluations. And not only in terms of health, but well-being, broader than health. What is the contribution of vaccine, for example, to other sectors of the economy? And we have all went through the COVID pandemic, and we have seen the potential of keeping economies open thanks to vaccines, but also to other public health interventions. Another issue in the IA 2030, which is important also for this priority setting, is that countries should have their own decisions and should be data-driven and evidence-based priorities, and not being kind of pushed or determined by external stakeholders. Finally, relevant to priority setting is that new vaccine innovation is a top priority. So it's not only about the new vaccine products that are in the pipeline, but also, in particular, I would say, the related technologies, including those technologies that ease administration, for example, macroarray patches that remove the constitution of vaccines, but also improve the thermos stability. So how do we see our role in WHO in the immunization department when it comes to product development pipeline? So we try to address the translational gap and the introduction gap. So when it comes to the translational gap from research development to licensure, it's really trying to identify those efficient pathways by using preferred product characteristics and identify those characteristics and attributes that address the deadliest disease, vaccine-preventable diseases, but also that are in need at the country level. When it comes to the introduction gap, we see our role really in educate, informing early innovators, manufacturers on the processes and the procedures needed to have vaccine uptake in low and middle income countries. And why are we in WHO focusing particularly on low and middle income countries? So vaccines are often developed, what we have seen in the past, with a high income country market in mind, which offer a near return of investment. But also the product preferences and attributes can differ, or they do differ in high income countries and in the low and middle income countries. Think, for example, of the strain coverage, the duration of protection, the storage conditions, a price tolerance, etc. And changing these attributes further down the pipeline will cause unnecessary delays for low and middle income countries for the uptake of these new technologies and vaccine products. Also the vaccine environment, evolving vaccine environment has changed and requires also new adapted schedules and technologies. Finally, the criteria and processes for recommendation and financing differ between high income countries and low and middle income countries. So we have, in the immunization department, we have developed what we call the full value of vaccine assessment concepts that we hope to help spur vaccine development that meet country preferences. And again, here you see the vaccine development pipeline. You have seen this in the previous talks too, but here specifically for vaccine development. What I would like to draw your attention on is the different stakeholders that are involved in the different stages of vaccine development. So it's not, it's including the vaccine recipients, the households, the healthcare workers, the communities, but also the academic institutes, pharmaceutical companies, countries, in particular the Ministries of Health and Ministries of Finance, but also international organizations. In WHO, we have an active role in the different stages of the vaccine development pipeline, but also Gavi is in place, UNICEF, and so forth. And not to forget, of course, the donor community, governments, and philanthropic institutions that play their role. And at each stage of the vaccine development pipeline, the different questions has to be addressed. So should we invest in developing a vaccine? Should we recommend or fund a vaccine? And should we introduce a vaccine? And so we think that with these vaccine value, the full value of vaccine assessments, the FEVAs, reports, we can help the different stakeholders in providing the evidence. And so the rationale for these FEVAs, or the full value of vaccine assessments, in particular from a WHO perspective, as an independent broker, is to guide and standardize the evaluations of generating the evidence at the different stages of the product development pipeline, but also the communication of these of the broad values of vaccines. We facilitate the alignment and the priorities between stakeholders, but also to improve the allocation of investments for vaccine development, policymaking, procurement, and introduction. So it's really a holistic assessment of the value of vaccines. And And in this recent publication by Trotter, we have laid down the elements of such an FEVA. So it's really to provide an early synthesis of the evidence, to better inform, communicate and align to a broad range of stakeholders the public health need of vaccine products and related technologies. By describing in these reports the supply and demand aspects, its markets, but also the impact from a health, financial and economic perspective. And so, so far we have established several FEVAs and have generated the related evidence for Group B Streptococcus, new TB vaccines, Group A Streptococcus, but also for measles, rubella, macroarray patches, and Shigella vaccine. So you can see this on this slide with the different elements of such a full value of vaccine assessment. And in WHO, we then steer these evaluations. We try to identify the research gaps from the top-down perspective. But also, we try to give these summaries to the different stakeholders, so including the international organizations like ourselves, but also for Gavi. So Gavi is using some of these FEVAs also for their vaccine investment strategies, recently for Group B Streptococcus, but also for new TB, new generation vaccine, TB vaccines. There are the RITECs, the regional and national immunization technical advisory groups use these FEVAs for their recommendation, but also ministries of health. So it's really from a multi-stakeholder perspective. But in the end, what we think is really the country context and the country needs and the preferences are important. And this brings me to my next slide, is that we also organize these country-level stakeholder workshops to identify the issues and the problems and where these new technologies can play a role. So really understanding the key problematic barriers, then identifying the preferred product attributes and characteristics, and how they can then also have an impact on these relevant barriers identified in the first step. We go with these different stakeholders to different use cases of the new technology and how it can improve the uptake of vaccines. So not only the products, but again also the ease of administration. I think we have to emphasize this coming out of the pandemic with a lot of hesitation with regards to the uptake of vaccines in different communities. So also thinking about these new technologies and trying to understand how new technologies can address these, but also to determine the evidence needs. So this is an overview of what we call these innovation framework workshops in countries. And here, it's just an overview slide where we have organized recently workshops in Africa, Asia, and Latin America with different stakeholders and different contexts, but identifying what the use could be of a macroarray patch in their context, or a thermostable vaccine. Or recently we have done workshops on oral cholera vaccine capsules. So let me finalize. My last slide is addressing the question, are we too early to inform priorities? I think we are not too early, because we think at any time in the vaccine development to implementation process, we can support the vaccine prioritization, but also identify the research and evidence gaps different stakeholders might need to spur the potential products and technologies through the pipeline, generate new estimates of potential vaccine impact, and confirm the potential value of promising vaccine candidates from a public health perspective. And these FEVA products we currently have developed are kind of not static, but really dynamic documents which we might update depending on whether new evidence might become available, but also whether the mandates of different stakeholders might change. And so we try to keep this as a living document, because the ultimate goal is to encourage new investments in innovative vaccines and related technologies, and again from a public health perspective. So let me thank my WHO colleagues working on these FEVAs in the different departments. And I would like to invite you also tomorrow to attend the session by my colleague Maarten Jansen, is also here in the room, in the Lotus Room, where he will share some more experience on our workshops in countries on using MCDA on innovations and the introduction of new vaccine products. Thank you.
Thank you. Thank you very much, Dr. Hutubessy. That was a really great overview of how early HTA is being really concretized in one field in vaccines. Because we've got lots of questions and we're running out of time, I'm going to go straight to the questions. So could we put up the questions that have come through the Cvent app, if that's okay, and then we'll jump straight to the questions. We'll go through the questions that have been asked first, and then if people want to ask further questions, feel free to come up. So let's take, Professor Ijzerman, there's one for you. HTA, by definition, early HTA may not have enough data for rigor. Would this lead to premature shutdown of the development of a technology? How would we know? How would we avoid this?
Yeah, thank you so much. I started answering some of the questions but I stopped because we need more words to explain what's happening here. So I think yes, but the certainty and uncertainty has always been an issue. And as an academic and a scientist, we always want to be certain. Those decisions are not 100% certain. And not all, I mean, I like the business development pathway, you may vary at a high level, aggregate decisions. Do we invest? Is there an opportunity for this technology to be developed? And you don't want to shut down promising technologies. But my concern here really is if you go very early, if I talk to basic researchers, we have no idea what product might be targeted at. You don't want to stop doing that. You still need your basic research. And the further you go down the line and the more specific you are about a product, you can be more strict about what's the value that you produce for society. And then you may shut down.
Great, thank you very much. Actually, that's a great answer. Maybe I'll jump to another one. Dr. Maneerat, maybe this question might, you might be able to help with this. You know, given that sorry, can we scroll down a bit? Yeah, given that there are agencies like NICE or HITAP are supporting health innovation because you are at the innovation stage, how do you think such agencies can be sort of more effective in supporting the work that you're doing? Because you are actually choosing which products to bring, which innovations to bring out to the pipeline, right? So how can the HTA agencies, which might decide whether to fund it in about 5 or 10 years' time, how can they support the work that you are doing right now? Could you tell us a bit about that?
Yeah, I think that is in fact something that Willie have already talked about in his talk. In fact, early HTA will help to bridge the gap. And what we are doing right now is quite similar. At first, we work with HITAP for trying to fine-tune the project as well. And when HITAP came to us and said, oh, we are conducting early HTA, we have this program setting up, and we are interested to work with the innovator, the researcher, so you have any promising project that you want to conduct early HTA. And I think this is the way that the organization like HITAP or NIST should work with the technology incubator like us or technology facilitator, so we can help to communicate between the two sides to make sure that it addresses the problem. And really also have addressed in his talk that early HTA is not just to help to evaluate the technology itself. It in fact is two-way. There is the interaction there. It increases the communication, the understanding between the two sides, between the technology developer and at the same time the user side. Because when we talk about innovation, we also need to educate the user along the pathway. And that's the process in early HTA. In fact, we just conduct a stakeholder meeting for one of our project together, and we're going to have more. And that's a series of meetings that we have to go through. And throughout this process, it will help the two sides to meet, and finally we get the right product for the right people.
Great, thank you very much.
Maybe also add this. Yeah, yes. So maybe also add to this question. So I think that's actually a good question. So when we first set Midas, we also have the same concern. To be more specific, Midas is supported by HITAP Foundation. So we are very clear about the works that we do and HITAP do. So for us, we work on medical innovation, and then for HITAP, they still do the traditional evaluation. So actually, that's actually a valid concern about, like for the HTA agency, so you work on the medical innovation. At the end, you also make try to do evaluation to help with the approval decision. There is a potential conflict of interest. So at the very beginning, we think about this one and then try to separate the work very carefully. But if you're interested in this one, I also encourage you to talk to Van Rudy or Dr. Yot from HITAP. I think they have a better, they will give a better explanation about how we try to avoid the conflict of interest here.
Thanks. Go for it.
Can I quickly ask a question to both of you? Because do you think, and the audience as well, do you think we need HTA experts involved in our innovation ecosystem and our business incubators? Because what I currently see is that the innovators, they call in HTA expertise when they're done with the development, and they expect us to develop a model to get reimbursement. That's not the thing we should do. Just please.
Yes, in our team, we have the health economists in the team, and we see the trend right now. When we get the health economists within the team, in fact, the researcher also come to that person quite a lot to ask the question and help the researcher in the process. And we just successfully, with this person help in the team, we got one of our products in the reimbursement program in Thailand already. So we just got the good news last month. So we were very happy with the result when we have such a person in the team.
I think I agree, and I think it should be a multidisciplinary kind of approach to this. As I said also in my presentation, really from a country perspective or patient perspective, looking at what are the real needs, and in particular, how we can improve, not only for reimbursement but also from a universal health coverage. Is this a technology adding to, the most populations that are in need of an issue we're trying to solve for?
Maybe go on.
Just to add to this question. So when we work with medical innovators, so we also ask them, so what particular expertise do you need from us? So in general, the response is, they say like they have little experience in terms of economic evaluation, in terms of HTA. So I think for sure for this health innovation ecosystem, we should try to involve the HTA expert. But when we explain to them, we also try to emphasize, so whatever work we do with you, so you should use this one to inform the innovation development. So this is not the document for the reimbursement decision. So say at the end, so you have a technology developed, you still have to go through the traditional HTA process, find another party, to do the evaluation for the reimbursement decision.
Great, thank you so much for the explanations. Maybe Dr. Hutubessy, could I ask you, pick one of these questions for you? So your work in WHO, which is really giving recommendations across so many different interventions, from medical vaccines to public health and social measures. Do you think there's a danger that early HTA will shift even more attention to the medical side at the expense of the non-pharmacological interventions, or do you think it's not, we don't have to worry?
Well, I don't think it will shift. I think I just gave the example from a vaccine perspective, but I think this concept of kind of an independent broker to identify the needs from a country perspective could be applied to other kind of technologies. And I don't see that this happening in other programs in WHO. But in particular also having the perspective from the countries through our country offices or through our partners to be at the table. And for example, we're doing these type of workshops at the country level, inviting a variety of different stakeholders to be at the table and to identify the needs in countries, and then feeding this back to early developers. I think that is what we could do more in the organization. Yeah.
Great, thanks. So maybe open the question wider. Do you think the early HTA could be applied to non-pharmacological interventions, like maybe early HTA of a tobacco tax or early HTA of a healthy eating program or something like that? Does it work, or is that just not the right concept?
Short answer is yes, you can. I think the longer answer is, I saw that question, and I think if it means that we will not prioritize work on non-pharmacological or preventive medicine, that will be a shame. That's a priority in itself. I think, in my view, why early HTA might be of interest is that we can prevent the technologies that were developed that have no meaningful value for patients or society. And if we can stop that development, we can release the funding and invest in other priorities. So that's my public perspective on early HTA. I can take a private perspective too, but that's my role is really in the public space. And the reason for being involved in this is because we had a program in a government-funded program, but where do we invest? In which companies do we invest? And that's a key question across the world. It's not just in Europe or Australia, it's across the world. What technology do we need to develop, and how can we release funding to really maximize impact for patients?
That's a great answer. And maybe that relates to another question that was asked. So early HTA is trying to address a few audiences, both maybe the private investors like the manufacturers, but also the public investors who want to improve the health of the population. How do you think the same concept can actually, supply information so that, all these different actors can get the information they need to bring something beneficial to society to the table when they're looking at different sorts of outcomes and benefits? Whether anyone wants to answer that question.
Yeah, so probably I will just start first. So I guess, so when I try to approach early HTA, so usually I don't really start from the health perspective. So usually I tend to start from the economic perspective. So I guess in a way, if we look at this one as an economic question, so at the very beginning, so we always want to make sure we have the biggest pie. And then later we want to decide how do we allocate the pie. So in a way, so I guess at this stage for early HTA, it's also like we try to do this work, try to increase the size of pie, and later we determine, okay, how can we do a fair allocation, or maybe a allocation that we can incentivize different parties to invest to their best extent. So I guess in this case, right, so potentially there could be some, like if the size of pie is fixed, one party get more, the other party, will necessarily get less. So when we try to do this work, as an early HTA researcher, so we want to take a neutral stand. So I guess we don't really want to prioritize one side or another side, but we more like want to improve the total social welfare. So I wouldn't really focus more on public and the private side, but at the same time, I think for the early HTA itself, so as mentioned, we also need to continuously develop framework because the question we are dealing with is quite complex. So in a way, we may also want to design a framework to think about the interaction between the public interest and the private interest. So what's the best way, try to facilitate this kind of conflict and also try to maximize the welfare.
I think to add on for the company itself is they want to think about whether to invest in early HTA or not, or what they can do. So when I build the impact measurement frameworks, we look at the potential impact as a goal, but at the same time, we do realize that there are some difference each time that we set up the funding scheme. We trying to be flexible so we can set if we want to put the economic value at first, so we do the weighting on the economic value. So we keep it small weighting. So then to make it more potential for the big pharma to license the product, to select the product at that time. So this kind of things can be tailor-made for each of the round of the budget that we get, or the grant from the company, the grant from the donor, or if the big pharma want to give us some budget to do something, that we can gear to what the theme or the vision of that round of the funding that we get from them as well.
Great, thank you. I think those have been great questions, and it's been a really rich discussion. I'm just going to end. We've got 1 minute more. Can I ask each of you to think about one key message about early HTA that you'd like to leave us with? So maybe if I start with Dr. Hutubessy, and then we'll come to this side.
As I said in my presentation, I think it's never too early. But for me, the main message is really, I would start with the end users to have their kind of preferences and needs being communicated to the early innovators and manufacturers of these new products. And I think we should also kind of think in more of, in all the presentations here, we talk about private goods, but also we need to think more in terms of common goods, where we can maybe get these evaluations more from a broader perspective, from a public health perspective, being evaluated.
Great, thank you so much. Dr. Maneerat.
I would say it's all about the priority, because you never waste if you want to do early HTA, although there are some room for us to improve early HTA frameworks. But the early you could do it, you can then release the budget to do something else.
Great. And Dr. Wang?
So I would say for early HTA, so we should consider both health and innovation.
Great. And Professor Ijzerman?
I agree with all of that. What I want to add is that we all assume in our presentations some sort of a linear process in a technology development and implementation. That's not true. Open innovation is the model, and it's hardly unpredictable what happens. So we should be conscious about this unpredictability.
Okay, thank you so much. This has been an incredibly rich session. Thank you so much for being part of this and for all the questions, and thank you.